Good morning, everyone. It's a pleasure to be here. Thanks to Rob and the committee for the invitation. I always love coming to New York before VEITH and potentially getting stranded on JFK's tarmac. We're going to talk a little bit about modern DVT intervention and how we reduce PTS severity primarily via guidance from pivotal clinical trials. And unlike a lot of the other things we do, we actually have RCT data that tells us what to do when we take care of DVT patients. Those are my disclosures. So we know that DVT is a big problem. 900,000 cases of PE and DVT, but between 60,000 and 300,000 associated deaths, and approximately 2/3 of those cases are associated with the known risk factors of illness, surgery, and immobilization. We know that the medical management of DVT is to prevent the extension of thrombus, prevent acute pulmonary embolism, limit the development of late complications of PTS that's been suggested in some larger trials, and reduce the risk of recurrent thrombus. But of course, it's endogenous fibrinolysis that manages the clot in situ after the event. And we know that despite optimal medical management, that there's a 5 to 15% risk of recurrent thrombus in most subgroups, and that PTS occurs along with the chronic venous insufficiency associated with ambulatory venous hypertension at a very high rate. From the ATTRACT trial, we know in a randomized fashion that up to 50% of patients in 2 years from the inciting event will go on to develop some form of PTS. It might be mild, but they will get some form of PTS, and about half of those go on to develop objectively severe PTS, and about 10% of those go on to develop an ulcer. We're still figuring this part out, the pathophysiology of post-thrombotic syndrome, but effectively our understanding is that thrombus deposits at a valve, causes an inflammatory cascade, damages the valve, damages the wall, and so what becomes a compliance vessel now becomes a rigid pipe, in which simply doesn't work on the venous side because there's a relatively weak pump on the back end of it. The risk factors for PTS over one VT event is an up to 6-fold increase in risk. Older age, suboptimal anticoagulation, of course that makes sense, and then persistent symptoms at 1 month from diagnosis are all risk factors for developing more significant PTS. We also know from trials that iliofemoral DVT is associated with a twice as higher likelihood for having a recurrent VT event, and then over 50% PTS rates, which has actually also been shown in prospective data. The severity of PTS is significant. It's defined by known metrics in the VCSS and Villalta score, but patients with the most severe form of this disease, which are frequently young, have a QOL on par or worse than diabetics, those with chronic lung disease and arthritis, and those with the most severe form of this disease are similar in QOL metrics to angina, cancer, and CHF patients. What guides our understanding of physiologic targets in managing acute DVT is the open vein hypothesis, and that is the idea that residual thrombus is associated with a poorer long-term outcome. The first larger trial to specifically evaluate this was this RCT from Norway in 189 patients. This is the GAVENT trial. 24-month PTS outcomes, they did notice a 14% risk reduction, but despite that, there was a 9% major or clinically relevant bleeding rate, and the average treatment duration, and this was catheter-directed thrombolysis, was 2.4 days. And that's really been the rationale for pharmacomechanical methods. Think about the fact that you're having a patient, you're going to do an intervention on them to maybe prevent the long-term outcomes. And that's a difficult thing to do to the uninitiated and to your referring providers, that, okay, they had a bad DVT, I'm going to stick them in the ICU to maybe prevent something that they have a 50% chance of developing, and there's associated costs with that and the associated risk. And so that's where pharmacomechanical methods have really kind of changed the game. This was a small study from 2006, 98 procedures, and they showed quite obviously that when you started using devices that actively remove thrombus, you reduced not only your ICU stay, but also cost reduction across the board. But really, the treatment of acute DVT in 2022 is based on the ATTRACT trial. This was published in the New England Journal in 2017. It is the largest trial to date and in a relatively unbiased manner, enrolled 692 patients with proximal DVT. This is a combined endpoint of FEMPOP and iliofemoral segment, and then there was a post-hoc separation of the cohorts. Their primary outcome was cumulative PTS according to the Villalta score over 5, just 5, and 6 at 6 and 24 months, with the hypothesis of a 1/3 reduction in PTS at 2 years with pharmacomechanical therapy, and then the usual secondary measures. And what they found, as you all probably know, is that there was no difference in PTS incidence. Think about severity, incidence of general venous QL between the treatment and control arms, and there was a higher major bleeding rate in the pharmacomechanical arm, but unlike the GAVENT trial, there were no fatal bleeds, there were no intracranial bleeds, there were, I believe, 3 Gusto major bleeds that were retroperitoneal hemorrhage that could be managed. So nobody died in this trial from receiving pharmacomechanical therapy, which is heartening that there are ways to refine the therapy. Now, if you split up the data, you can see that in the iliofemoral cohort, there was 391 patients. And though they didn't show any difference in occurrence of PTS, there was a decreased moderate to severe PTS severity. And so specifically in patients that presented with a Volta of 10 or 15 or greater. Now, you might ask, well, Volta is a PTS metric. Why are we using that to talk about acute DVT patients? Because we have no way of talking about acute DVT patients. We have no way of systematically talking about how severe the symptoms are. So in a paper that was just published in JVIR, which I was given the honor of writing the editorial for, we now know from a prospective RCT that you can actually use the Volta trial, the Volta scale, to talk about how severe DVT symptoms are up front. So if you have a patient with iliofemoral DVT and has a Volta of 10 or greater and has a robust QOL ahead of them, robust activity level, that patient's probably going to do well from treatment. And so this is an incredibly powerful thing. Certainly we don't need to stop there. We need to go and find a DVT metric, but in the meantime, we do have this. What about in patients that just have FemPop? And this is what we have probably the most questions about, isolated FemPop disease. And I think, at least in my opinion, based on what the ATTRACT cohort showed, there was no difference in all PTS, no difference in moderate to severe PTS, and no difference in venous-specific QOL, and there were some bleeds. So the take-home here is that there is no apparent long-term benefit in this group of patients. Are there isolated patients that might get better? Yes, but it's certainly not the tsunami that I think I'm seeing, where a lot of FemPop DVT is being treated that is not clearly indicated. So the perspective here, should it be the first line in all DVT patients? No, but in iliofemoral DVT, I think in patients that are young and relatively low, good risk profile and are expected to have good outcomes and want to reduce the risk of PTS. We're not talking about the sedentary patient. We're talking about the patient that's going to want to run several miles a day or walk or play with their kids. This is a therapy that really works. In terms of timing of the intervention and patient selection, we talked about picking iliofemoral DVT patients primarily. The 14 days in ATTRACT and 21 days in COVENT are straight up made up numbers. We think that, and there is no, and that's not a criticism because I would make it up too. We don't know what the optimal timing for treatment is. The problem is that patients probably organize clot at different rates because it is an inflammatory process, and young patients have a more brisk inflammatory process. Older patients have a slower inflammatory process. And so there's probably somewhere in the middle. I've certainly treated patients out to 3 to 4 weeks, and I've certainly gotten patients at 10 days and I'm like, this is rubber. This is not acute clot. It's already organized. So there's something to that. You want to think about what your goals of thrombectomy are and manage expectations. So my goal is to remove thrombus, restore patency, and limit that valvular damage to reduce the severity of PTS. Personally, if there's chronic occlusion, that is not clot. I'm going to say that, I'm going to stand on that hill. Chronic occlusion is type 1 and type 3 collagen. It is not clot. You cannot remove it because you are not leaving behind a scaffold. A vein that cicatrizes closed after chronic post-thrombotic occlusion is now no longer a conductance vessel, and it's not like atherectomy on the arterial side where you're going to leave behind a pipe. All you're leaving behind is basically connective tissue. So I think we need to really get away from talking about removing chronic clot personally. So just to wrap up with the case, this is a 35-year-old male, no prior history of DVT, half pack per day smoker, and he has new onset left lower extremity edema and pain. He did have a lap chole about 2 months prior, which I didn't think was a risk factor, but my hematology colleague says no, anytime 4 or 5 months before we considered that a risk factor. So as expected, common femoral DVT completely occlusive in the left common femoral vein. We get a CT scan to look at it, and it's not just an iliofemoral DVT. There's quite a bit of extension into the vena cava. So we're going to have to think about how we want to manage this. Can we do this all in one single setting? Can we do this from one access? What kind of devices are we going to need? And there are many devices you can use. There's no one right way to do this. So personally, in this patient, this is probably one of the few patients in an acute DVT intervention I would place a filter. And what we did is with him prone, I got bilateral POP access. There's one device that can be deployed from the POP in terms of a filter, and that's the argon option filter. So I went up and I placed it suprarenal. We placed that filter above that cast of clot that you can see right here. And then we start working on performing thrombectomy. And what I did is from my right-sided axis where everything is patent, I actually had an IVUS catheter. And on the left, I used a Cat 12 penumbra catheter. And then under dynamic IVUS guidance, and I'm going through this in the interest of time, I actually performed thrombectomy. So I engage a clot, and once I engage a clot on IVUS, I flip the switch, pull it out, and actually watch myself pulling it out on IVUS, close the switch, move down, and work my way down to clear out the vena cava. It's the easiest way to do it because otherwise you're kind of guessing where the clot is, and here you can actually actively see yourself removing the clot. This was very easy to clear, as you all know. These thrombectomy devices nowadays are brutally efficient. It took all the clot out of the femoral vein within one pass. The expected post-thrombotic change in the left common and external iliac vein. We get everything open. We perform the IVUS. This is after thrombectomy. You can see that the cava is now completely free of clot. And then we perform the IVUS of the iliac vein. We place our stent as would be expected. And we might be seeing some stent cases later today. So a nice result at the end. Perform the final IVUS of this. And I apologize, I'm going through this quickly. And then importantly, before I put this patient under general anesthesia, because I was going to do this under general anesthesia, I had actually placed a micropuncture sheath in his EJ. And then with him in prone and in a prone view, I just retrieved the filter with him prone. Took it out right then and there. That way I don't have to think about it. He doesn't have to come back. No other additional sedation. The whole case is done. So I took the filter out, as you can see here. I wouldn't suggest doing a 16 French sheath with him prone, but a 12 French sheath is fine. He's done great. This is his follow-up CT. He's now a year out. Everything's open. And a great result. So to conclude, long-term PTS sequelae are a known risk factor associated with DVT. The emerging technologies have really shown promise in iliofemoral DVT management, and we have prospective data. I don't think we can say that about many vascular diseases, but we have prospective RCT data that actually informs us on how to treat these patients. So I think we should look at that. Thank you.